Oh, I'm sorry. I thought she was timing me.
You know what? I'll let you know. Are we live now?
Yeah, so I think that's all I had to do, right? Was start broadcast?
I think
Yeah,
so.
it says live.
Okay.
So I'm just going to welcome everybody. I'm going to thank Jennifer for opening our channel here. And we also have Donna, Cynthia, Mike, and myself. So we're going to go ahead and we're going to do our presentations first. Then we're going to move into the discussions. Discussions supposed to last somewhere between 45 to 90 minutes. We'll probably spend about 5 to 10 minutes on a question. And just to be sure that everyone's getting a chance to participate, I'm going to kind of just go in order. And, you know, question number 1, I may say Mike, or question number 2. And then once Mike's done answering, then anybody can pipe up and say what their opinion is as well. So all that said, let's get started. Donna, are you ready?
I'm ready.
Okay, I'm going to record you.
Okay.
All right, so tell me when you're good to go and I'll just start it.
I'm good to go.
Okay.
The title of this quality improvement project is Improving Patient-Centered Weight Management Care in Adults with Obesity Using the 5 A's Toolkit. The aim statement is to improve patient-centered right care for adults with obesity to 80% in 90 days. As of 2016, nearly 40% of adult Americans are obese, constituting a national epidemic with an upward trend. The adult obesity rate in Duval County, Florida is 31%, in contrast to the state prevalence of 28%. Over the next 16 years in Florida, obesity is expected to contribute to millions of cases of preventable chronic diseases such as diabetes, hypertension, heart disease, and some types of cancer, costing an estimated $34 billion. In Healthy People 2020, one of their objectives is to increase the proportion of physician office visits made by adult patients with obesity that include counseling or education related to weight reduction, nutrition, or physical activity. This objective is also supported by the U.S. Preventive Services Task Force and the American Heart Association, American College of Cardiology, and the Obesity Society's 2013 guideline for the management of overweight and obesity in adults. After a 20-patient chart review and 7-member teamwork and 20 patient engagement surveys, existing quality gaps in weight management were revealed. 44% for teamwork, 40% for patient engagement, and 63% for right care bundle. The right care bundle gap consisted of non-compliance rates of 40% not receiving a diet plan, 55% not receiving an exercise activity plan, and 95% not scheduled for a designated weight management follow-up visit. The expected outcomes and benefits of the QI project include bridging the gap in weight management care at Baptist Primary Care, Arlington, to at least 80%, and even to 100% is the dream. Team benefits include improved teamwork, skills, engagement, knowledge about the topic, and the ability and confidence to counsel patients with obesity. Patient benefits include an increased awareness of the problem of obesity and need for change to achieve better health outcomes and improved experience of care and engagement. Organizational benefits include better health outcomes for delivering evidence-based right care with evidence-based guidelines and standardization of care. This in turn is expected to bring financial benefits to the organization due to increased weight management visits, improved patient satisfaction, and increased referrals to the practice. The process operational definitions are shown here for ramps A through D, one balancing measure, and the aim statement. As a balancing measure, maintenance of team satisfaction with the implemented changes will be measured by the mean scores on a teamwork satisfaction question as part of a teamwork survey. The aim of the project will be measured by B outcome plus D outcome divided by 2. Here's a picture of myself with the primary stakeholders and a complete stakeholder listing that includes the mentor, Dr. Meredith Riddle, the sponsor, Perry Nolan, the DMP clinical faculty, Anna Brazzoni, and Baptist Primary Care's Chief Medical Officer, Dr. James Clower, Vice President, Marcia Donaldson, and the Director of Operations, Virginia Hosang. The initial changes for ramps A through D are listed here. The core intervention for teamwork will be a kickoff meeting and weekly meetings thereafter. The 5 A's Obesity Management Toolkit will be utilized to foster patient engagement with the use of a modified shared decision aid, the SMART Goal Sheet, Patients will be asked to develop a SMART goal for one lifestyle change, and their confidence to do so will be measured as well. Process changes will be implemented for ramp C and D. C ramp utilizes the readiness ruler to first assess the patient's readiness to change before proceeding to their SMART goal development. D ramp utilizes a weight management follow-up log to document the patient's follow-up visit, phone call as needed, SMART goal development, referral if indicated, and their next steps. The primary barriers for teamwork and patient engagement are the same, which include a lack of motivation, engagement, and knowledge. The barriers for the process changes include scoring a 0 on the readiness ruler, which indicates the patient is not ready to make a change, and a lack of follow-up. No designated weight management follow-up visits, SMART goal not developed,
20
and
seconds.
SMART goal and next steps not initiated. And these are my references. Thank you.
Terrific.
Sorry, I'm okay.
That was great. And actually was able to follow that pretty clearly, even though it wasn't ideal.
I'm sorry. It's just, anyway.
Technology. Okay. So I guess we'll just go on to the next person and save discussion till the end. Let's see, Mike, do you want to go next?
Sure, I'll go. Let me figure out how to share my screen here. Can you guys see my screen okay?
Yes.
Okay. Well, we'll get started here. All right. So, hello, everyone. Welcome, and thank you for joining me for my presentation of my quality improvement project at the University of Kentucky Medical Center titled Improving the Implementation of Patient-Centered Smoking Cessation Therapies for Hospitalized Patients with Cardiovascular Disease. The aim of this quality improvement project is to improve patient-centered smoking cessation therapy implementation in hospitalized patients on the cardiovascular service line from 45% to 80% within 90 days. So to begin, let me share a few facts about the burden of cardiovascular disease and smoking. The estimated cost of cardiovascular disease in 2013 was $204.8 billion. And the cost burden of the disease is predicted to increase 100% by the year 2030. Smoking is the leading preventable cause of morbidity and mortality worldwide and is responsible for 1 out of every 4 deaths from cardiovascular disease. Current estimates report that there are 34.4 million smokers in the United States, which equates to about 14% or so of the population. In Kentucky, where I live and work, approximately 25% of the population smoke. So we have a much higher percentage of smokers compared to the national average. Given the burden of the disease, I want to see if this is an area in which a QI project at my employment site would have a positive impact. So I performed a chart audit of 20 random charts to gather baseline data and identify any gaps in care. Several gaps were identified and included provider secondhand smoke exposure screening, initiation of pharmacological cessation therapies while admitted, provider counseling, tobacco specialist consultation, and discharge prescriptions for cessation therapy. Provider and patient surveys were collected and a patient tracer was performed, which helped identify a knowledge deficit in both providers and patients and communication gaps. The expected outcomes with the implementation of the project are to promote a practice that incorporates right care, reduce overall morbidity and mortality associated with smoking and cardiovascular disease, increase the standardization of care, improve patient-centered care, improve patient engagement, improve team function, and reduce overall healthcare cost. On this slide, I have listed and defined the operational definitions for each process and outcome in each of the 4 ramps of the project. I also included the balancing measure, which is team satisfaction. And then on the bottom, I have the operational definition of the aim, which will be calculated by the B outcome, which as you see above was average patient engagement score, and the D outcome, which is the percentage of right care delivered divided by 2. So using the baseline data, the aim calculated using the formula prior to the start of the project is 45%, and the goal of the project is to increase that to 80%. Here are the key stakeholders. They include the providers, the staff, the patients admitted on the cardiovascular service line, unit manager, the assistant chief nurse executive, and of course the DNP faculty. In this graphic, I've listed the initial changes or core interventions for the project. For the A ramp or the team ramp, I'll perform weekly QI meetings. For the B ramp or patient engagement ramp, I plan on utilizing the Get Well Network video system. For the C process ramp, which is screening, I will implement a provider algorithm checklist based on current guidelines. And for the D process ramp, which is right care, I'll utilize a case management log to assist with tracking right care. To better assess and plan for barriers that I might run into while implementing the project, a cause and effect diagram was completed with the staff, and the barriers for each of the 4 ramps are identified and listed here. My goal is to overcome each of these barriers through the utilization of my core interventions for each ramp. And here I've listed the key references, including guidelines that I've used in formulating the project. And that's it.
Terrific. That's excellent. Okay, and we'll just move right on to the next person. Cynthia, are you ready? Cynthia, are you speaking? Are you there, Cynthia? I can't hear you. Are you on mute? No.
Can't hear you.
Maybe try unplugging your thing and plugging it back in. If that'll help. No.
So funny, it was working before.
Mm-hmm.
Yeah.
What if you just unplug the headphones altogether?
Yeah, I did.
Oh, I can hear
Oh,
you
there
now.
it is.
Now we heard you.
Oh, maybe there was like a delay. Okay.
Yeah, you're good.
Oh, all right. So thank goodness now you can hear me. Okay, I'll screen share again. Sorry about that, guys.
No worries.
Technical difficulties. Share. Okay. Can you hear me now?
Yes.
Okay, so I'm Cynthia Forrest, and my quality improvement project is increasing effective antibiotic stewardship in urgent care utilizing shared decision aid and a 5Ds tool. So my aim is improving patient-centered right care for patients with upper respiratory and/or HENT viral illnesses presenting to urgent care by 80% within 90 days. So overuse of antibiotics leads to antibiotic resistance. And in the 1940s, infections were the leading cause of death. Now we are headed for the same kind of crisis because there's no new antibiotics on the horizon. And effective right care is vital. According to the CDC, strep pneumoniae has a resistant rate of over 1 million cases a year with 19,000 deaths. This slide shows our counties, Fulton and Montgomery, in the right middle area. You can see those 2 red strips with the very high use of antibiotics. especially quinolones and azithromycin, which makes it a more serious threat. The white areas on the left in the western part of the state are where there are university hospitals where they're doing much better than we are. So the reason for my effort, I did 2 chart reviews that indicated that 75 and 85% of providers were still prescribing for viral illnesses. The team engagement was 47%. There were no interdisciplinary meetings. The providers were pretty much left out of the loop of communication. And a team survey showed that the LPNs felt that their personal conflicts really did not affect patient safety about 50% of the time. Patient engagement was low at 33%. And the cause and effect diagram indicated that there was problems with following up with primary care providers. So my expected outcomes has very high peaks vision. I hope to get prescribing back to a standardized, proper, evidence-based practice, and at the same time increase team and patient satisfaction and engagement. This will also ultimately, hopefully, decrease resistant organisms and help our standing in the state data. And I hope that they can continue my quality improvement. And this is my measures worksheet. The aim is B outcome, patient engagement score over patients identified and screened. The team quality meetings will have a concurrent scoring of a Likert scale 1 to 5. Patient engagement will be hopefully through the shared decision-making aid. And then we'll have the proper prescribing guide and a case management log. This is my interdisciplinary team. And in the highlighted areas shows the pharmacist, who is fantastic and has been helping me. The MedDent EMR administrator is going to help with reports through the EMR to track things in my chart audits. And the new urgent care navigator is going to help with referring to primary care and be sure we have good follow-up. So my initial core interventions are going to be a bi-weekly team meetings, the shared decision aid and patient survey, the proper antibiotic prescribing 5Ds tool, which has the right dose, route, interval, and that it's the proper antibiotic being used, and then the case management log to be sure we have proper follow-up. The barriers are mostly time constraints, heavy workload, preconceived ideas, inconsistency in practice. Thank you so much. And here are my references. Thank you.
Okay, that was great. Thanks, Cynthia. And Jennifer, you ready?
I'm ready. All right. You guys can hear me okay?
Perfect.
All right. All right, you guys can see that?
Yes.
Okay, perfect. All right. So my name is Jennifer. I'm based in Sarasota, Florida, with Gulf Coast Obstetrics and Gynecology. I'm a certified nurse midwife. And my project, or our project, will be implementing effective right care of weight gain in pregnant patients in a suburban obstetrical practice. So the aim statement for this project is to increase effective screening and right care of weight gain in pregnant patients by 80% within 90 days. So why is weight management in pregnancy important? In the United States, more than 50% of women are considered overweight or obese at the onset of their pregnancy, and 48% of women gain above the recommended guidelines. Women who gain too much in pregnancy, who start pregnancy at a higher BMI, are at increased risk for adverse pregnancy outcomes like gestational diabetes, hypertension, preeclampsia, and they're also more likely to have a cesarean delivery with an increase in wound disruption and infection. Overweight and obese women use more healthcare and physician services, are less likely to see nurse practitioners, have more antenatal screening, and also have longer hospital stays. This translates into a cost of care increasing by 5 to 16% of women of normal weight. So 20 charts were audited at Gulf Coast OBGYN. Of those 20 charts, 80% of women had a pre-pregnancy BMI of 25 or greater, and 40% of those women gained more than the recommended guidelines. No patients received educational materials, and only 1 out of 20 received specific dietary counseling. Obese patients should be referred to nutritionists during their pregnancy, but 94% of patients were not. BMI was documented on 100% of those patients, but no screening was performed to assess for abnormal weight gain. There's also no shared decision aid in place, although 83% of patients expressed they'd be interested in a tool like that. And then team communication was identified as a gap, with only 69% saying their provider discussed daily plans with them. Only 69% agreed that feedback was given in a positive way, and only 64% of staff felt that this other staff acknowledged each other's needs. So expected outcomes from this project are increased team and patient engagement, improved health outcomes, and reduced costs to the community. Preventing excessive weight gain in pregnancy will reduce costs to both the practice and the state by reducing the need for increased healthcare services like antenatal testing and surgical delivery. Some deliverables from this project will be screening processes, screening tools, and the shared decision aid. So this is my measures worksheet, as you can see, with the operational definitions for the AIM, the A through D ramps, and the balancing measure. So my AIM statement is a combination of my screening and right care, so my screening process and my right care outcome. And my balancing measure is really not to lengthen the visits too much longer with using the shared decision aid. So it's a picture of some of the MAs during our cause and effect diagram portion of the project. So the key stakeholders will be, I'm really focusing on the 4 midwives in my practice and the 1 nurse practitioner. We do see the bulk of the OB patients, and we see all initial OB visits. The staff, so we have a staff of MAs, which I'll go into barriers in a second, but we are understaffed right now, so that's a little bit of a challenge. Of course, the patients, and then Healthy Start in our community, who provides free nutritional counseling to patients. So initial changes, so we'll start with weekly meetings with the team, along with a team engagement survey. The shared decision aid with patients, which also includes a SMART goal, and they'll also be followed by a survey. Screening for BMI and abnormal weight gain, and then the case management log to make sure that the patients are receiving right care. So barriers are staff compliance due to increased workload, which I plan to mitigate with defining team member roles. Provider compliance due to time constraints, so hoping to give supplemental educational materials to patients so providers can not spend a huge amount of time counseling. The inadequate medical staffing levels, so hoping to communicate with the lead MA and then shift staff as needed. So if a provider is not busy or leaving for the day, that staff member can go and help another provider. And then patient compliance, so that will be reaching out to them. Right now, our patients tend not to respond back to Healthy Start, and so I'm hoping the phone calls a week later will help make that connection for them. And then these are my references. And that's it. Thank you.
Great. Thanks, Jennifer.
Oops, let me stop sharing my screen, so sorry.
Great job. Thank you.
Thank you.
Okay. So I guess it's my turn. Just bear with me for a sec. Can you guys see the presentation there?
Yes.
Okay. All right, so my name is Julie Jarsma. My QI project is patient-centered obesity management in an Afro-Caribbean population using motivational interviewing at an urban primary care practice. My practice is my Health and Me Clinic, which is located in Brooklyn, New York. The aim of this project is to increase patient-centered and expert right care for adult female patients with obesity at my Health and Me Clinic to 80% by June 21st, 2019. So the incidence of obesity in the United States hovers around 40%. When we're looking at African American women with overweight or obesity, that incidence rate skyrockets up to 82%. The burdens of obesity are well known. They include heart disease, stroke, various cancers, and type 2 diabetes. And the costs are staggering at close to $150 billion annually and up to 21% of all national healthcare spending. So there's numerous gaps in management for obesity at my clinic. A chart audit revealed a right care score of 7.5%, with only 30% of our obese patients receiving dietary advice and only 25% receiving advice about exercise. Team surveys revealed that the providers are not necessarily comfortable discussing obesity with patients and lack familiarity with obesity guidelines. And the patients felt that the providers weren't involving them with decision making and goal setting, and they did not feel that the advice was culturally relevant to them. So expected outcomes of this project is to standardize patient-centered management of obesity in our clinic, to leave some process tools in place for evaluating right care. We want to improve the cultural relevance of the materials we're giving to our patients, and we want to increase the provider comfort in discussing obesity. And we want to do all of this with minimal increases in cost. So for measures, you can see that for the team ramp, we want to increase the average team engagement score. It's about 80% now, but I'm rerunning that survey. The patient engagement, we want to increase from 74%. For the C process ramp, we want to increase our average provider right care score. That's at 34% at this time. And for our D process ramp, we have a right care case management log, which again is hovering at 7.5% for baseline. Balancing measure is average visit length time. We do not want to be increasing our visit lengths much further than they already are. So the key stakeholders for this project include Dr. Campbell. She is the owner of the clinic and the primary provider. The team includes a medical assistant, receptionist, and then we have just ongoing rotating students coming through who act as providers. We have the FNU faculty involvement and the patients as well. The initial core interventions for the A ramp will include weekly team huddles. And this will include opportunities for discussing and educating the team, including motivational interviewing, as well as increasing familiarity with the guidelines. The patient ramp will include use of shared decision aids, and these aids are being altered so that they're more culturally relevant. They have pictures of people of color. They have foods that are popular in this demographic, just something that people can relate to more. The C process ramp is the provider checklist with a screening. So it will identify patients with obesity, and then the provider can go on and follow the checklist. And for the D process ramp, we'll be using a right care case management log. And so there's numerous barriers. For providers, again, it has to do with awareness of guidelines and comfort level in discussing obesity. For patients, there's numerous barriers, especially involving socioeconomic and cultural factors. These include things like poverty and food deserts, and even differing cultural views on obesity, and sometimes more acceptable, so it's harder to convince people to lose weight. And also patients have a discomfort with discussing obesity with the providers. And the C process ramp and D process ramps are both similar because there are no existing policies or procedures for providers to follow. There's no tools to guide the providers in care, and there's no tools to track the right care of patients. And here are my references. Thank you.
Great job.
Thanks. Okay, so I guess now we'll move into our discussion segment. Does anyone have anything they want to say before we go into the questions? You good?
You're still sharing your screen.
I'm still screen sharing, thank you. How do I unscreen share?
Just hit the same button.
That green one?
Yeah.
Julie, did you time me, and do you mind giving that to me?
I did time you. I think it was about 4 minutes, 50 seconds.
Thank you.
Mm-hmm. Okay, so the first question listed here is, the question is, who told a compelling story to support their problem? And what was it about their story that compelled you specifically? So we'll start with Cynthia.
Okay. I liked Julie's story because it not only told, the risks of obesity and the health risks, and that it's over $150 billion a year and takes up over 20% of all healthcare spending. That's very significant. And I think she pointed out it really is difficult for providers to talk with patients about. It's a very delicate subject. And I liked how she talked about the cultural disadvantages. The African American patients sometimes struggle with this more. And I liked the way she pulls in also the Caribbean population as well. And that she discussed sometimes food deserts, and, that sometimes the transportation to get fresh foods and things is really a problem. And I thought it was interesting that there's such a huge gap with the standardization of tools for the providers to even use or trigger them to use to help, even start the topic with the patients. So great job.
Thank you. Does anyone else have want to talk about compelling story that they saw in somebody's presentation?
I would like to say that I thought Harold painted a good picture of his topic, and I just found the rationale very compelling and believable, and I thought Harold did a good job.
Don, I really liked how you talked about obesity in Florida, because I live in Florida, so I was surprised actually that it wasn't higher. So that was pretty interesting.
Donna, I also particularly liked your presentation voice. It's very engaging. So somehow you're able to take all the statistics and make them user-friendly.
Oh, well, thank you, but I was shaken.
All of the stress of today, you still did a great job.
Thanks, Julie.
And Jennifer, I thought your presentation, you had some great graphics there that just made it also another type of user-friendly. It kind of pulls you in and makes it easy to look to.
Thanks. I liked how everybody had pictures of either their practice or the team, or it just gives you an idea where people are working.
Yeah. Some real varieties there too.
Yeah.
And Cynthia's beautiful mountains. And
yeah, it was nice.
That was relaxing.
I like the county map that you used that had the antibiotic use rate.
Yeah,
that was
and how you talked about how the university area had the lower antibiotic use rate, which is probably because they have students and they stay up to date on guidelines, antibiograms, things of that nature.
Yes.
I think that really hit that home.
Thank you.
Now, Julie, do you really go to Brooklyn every day for work?
Oh my goodness, yes. It's
oh my gosh.
I'm excited.
2-hour commute.
Yeah, my dad used to work on in Wall Street, and so it was 2 hours each way. So I was surprised.
Whoa.
You know what I go through.
Oh yeah.
It's a love. All right, so the next question is, from a graphic design standpoint, whose PowerPoint presentation was the most appealing and why? I guess we've kind of touched on that, but Harold, do you have any more you kind of want to add? Or Harold, Mike, I apologize.
Yeah. So I really like Cynthia's background. I thought the pictures were just beautiful. And so that was really appealing to the eye. And then Julie's PowerPoint I thought was very clean, yet also wasn't boring. So it kept your attention. It was easy to read.
Yeah, I literally wrote the same thing about Julie's clean slides.
Oh, thanks.
Yeah.
I was actually going to say, Mike, I liked your presentation the same way. It's you were able to, in one picture, sort of present things in a very readable, organized way. You even had almost a Venn diagram going on there. It was nice. Made it very easy.
That's what I wanted to say was Mike's, I thought, had really excellent, the way you put the boxes, the dark red leading into the others. And your slides were very organized, and I loved it the way you put it all together that way. It's very clear.
Thanks.
So question number 3 is, who presented data and numbers the best? What format helped you, the viewer, to understand the documented data supporting the problem? Again, I think we've kind of touched on this, but Jennifer, do you have anything you want to add?
No, I think everyone did a good job of it. I agree. I actually think we all presented data in a similar way. It just kind of fell together that way.
Yeah.
But no, I really liked, and I noticed, Dawn, I know yours was a little hard to see in the beginning just because of the phone, but I could see that you had some graphs there, and I think that's helpful too.
Yes, I think everybody did a great job with that.
Okay. Question 4 is, who engaged the audience the best and why? What specifically did they do that was engaging? Donna, that question starts with you.
Well, I wrote Jennifer's name down. I found that it was very easy to understand her, and I really, excuse me. Is that me? Is that feedback from me? Can you hear me?
Yes.
Yeah, I can hear you.
Okay, it just must be feedback. Okay, so anyway, I thought Jennifer's was very appealing, and therefore it engaged me. I liked her expected outcomes slide and the barrier slide. I like that she not only listed, for example, the barriers, but also went into the strategies.
Thanks.
And I liked the food pictures on Julie's. It really kind of kept you with the theme. It made me very hungry too. They're very beautiful.
All right. So the next question is, which health disparities were included in an operational definition presented? And challenge question, could you include this? So I'm not entirely sure I'm fully understanding this question, and that's great because it starts with me.
Let me just say, Julie, I kept asking myself the same question. What is 5 asking? But, you know,
I'm glad I'm not alone.
I will say that the outcome seems to be, the operational definition for the aim seems to be very similar, you know, as far as the operational definition for all of us.
Right. And then and somehow they want disparities, health disparities pulled into that. I know my project deals a lot with health disparities, but I think because the entirety of my clinic is this Afro-Caribbean population, it's not really able to compare it to a wider population. So that's not, that couldn't be part of my operational definition. I'm not sure. I don't think any of you necessarily had that opportunity either, at least in your operational definitions, if I'm interpreting the question correctly.
Yeah, no, I focus just on pregnant patients, so I'm not limiting to a subset of our clinic is very diverse in our patients. So,
right. So I guess we could ask the challenge question is, could we include this? And I guess in my case, I feel like I don't have enough of another population to compare to, so I'm not sure that would work in on my project. Does anyone else have any kind of thoughts about that?
I guess my 2 chart audits, one was adults, which ended up being mostly white. But then when I did the pediatric one, there was a large Hispanic population. So, you know, I'm not sure if I could work that in somehow. And they mostly were Medicaid, the pediatric patients that I audited.
It's actually an interesting question. Like, were you able to see from the data if your Medicare patients were less likely to receive right care with the antibiotics or not?
Well, it actually, the pediatric audit, they did get more antibiotics. But I included acute otitis media in there, and no one was doing watchful waiting. So I think that was a big part of it, as well as pharyngitis. The adults had sinusitis and bronchitis as well. So that's a very interesting thought that, you know, maybe the Medicaid patients get more. I'd have to look at the adults insurance, but some of those, I think that was about half Medicaid, the adults.
I wonder too, though, with the pediatric population, if it's more giving the medication to make the parents happy. I come from a pediatric background, and that seems to be, you know, just you want to make the parent happy, and so you're giving them medication quicker than it's an easier conversation sometimes to have with an adult with their own health and with a parent with their child.
Yes, the concern and the the worry about daycare or childcare. You know, I think that's a big part of it as well. And I think there's also an element of inexperienced providers or providers that don't have a lot of pediatric experience. They, you know, there is a little bit of fear, you know, when you see a sick child, you know, I think they're more apt to treat.
Oh, same thing with the pregnant population for sure.
True.
Yeah, we're quicker to throw or to work up, you know, give them everyone $1 million workup than if they were someone coming non-pregnant coming through the ER.
Right.
Interesting. Okay. So moving on to the next question. This one goes back to Cynthia. What prep did you do that helped you stay on time, not read your presentation, and engage the audience?
I think this time by not reading it, I thought about it a lot, like forming it in my head before I started to practice. And then I would time myself in practice and make myself not read. And it actually is easier, I think, not reading it. And I think, you know, when I've done presentations in the past outside of school, I'm more relaxed than in school. I'm just so nervous for some reason. So I think that not reading it really helped. So how about you guys? What did you do to overcome that?
Practice. I pretty much memorized it, I think.
It shows. Great job.
Yeah. I feel like at this point too, we've kind of been working on this for a couple months and feeling more and more familiar with these statistics. And it's kind of different than when you're doing a presentation that you've just been given an assignment and a week later you're giving a presentation. You lack that comfort or familiarity with the topic.
Yes, definitely.
I tried to use some, oh, I'm sorry.
No, go ahead.
Cynthia. I tried to use some inflection in my voice. And I did do some research on PowerPoint prep. So, you know, I was taking in a lot of tips as I made my PowerPoint slides, trying to make them as succinct as possible and so forth. So hopefully that engaged you.
Yes, it did.
It did. But Donna, when you were doing that research, did you happen to do research on speaking through it? Because like I said before, that was particularly great how you conveyed your voice.
No, but I did read and I haven't applied it, but I would like to in the future. One of the main points that I learned about being a good speaker or giving a good presentation is to have that compelling story and to tell stories. So the great presenters are those that tell stories. And I'm not really a storyteller. So that would be something that I'm going to work on.
Good point.
So as we get some results, you know, we can make our little anecdotal stories and pass them on to the stakeholders to further engage them and also to really sell our new process that we're coming up with.
Well said.
I think that's an excellent point. Okay. So the next question is, what was the most innovative, creative intervention and or outcome presented? And that goes to Mike.
Well, I think the majority of us used some sort of shared decision aid. But then I know I can't show you what my patient engagement tool is because it's a subscription service, but the Get Well network that I'm talking about is an interactive video program that's on all the patients' rooms on their TVs, and they actually have wireless keyboards. And so the provider orders what videos that they want.
Wow.
And it goes to the patient's TV, and then it automatically pops up, and then they have to click on it to watch it. And then once they do that, it then goes back to our electronic system and shows that they've completed it. And so that is pretty innovative. I mean, I didn't create it by any means. I just want to use it.
Take advantage of it. When you mentioned it from the last touch point, I thought that was so cool.
Yeah.
Amazing.
Do you find that patients are using it?
Well, they have been using it for like certain things are automatically populated on there based on their diagnosis, but things like, since my project's smoking cessation, essentially, those don't automatically populate. So the providers will have to order it. But yeah, they kind of don't have a choice because it pops up and they have to click on it and at least acknowledge it before they can watch TV.
That's brilliant.
Yeah.
Right. Let's see. Did any of other of us have innovative or creative interventions? I don't think I did. No? Okay. So moving on, what was the most difficult aspect of this term and what helped you overcome it? And Jennifer, you can start with that.
So I think for me, the most difficult was not being able just to knock out assignments. It really requires, I mean, this is what I found, it requires daily work. And so I'm on call, and I'm on call at least once a week. And if I'm on call the weekend, I'm on call a weekday during the week and also on the weekend. And my calls are long, and so we're very busy. And so that was really challenging for me, was to come home at the end of the day where I just want to kind of chill out, and really having to put work in every day. I don't know how you guys feel the same way, or you're used to knocking assignments out like when you have a day off, and it's really, you can't.
Yeah.
Yeah. I agree very much so. I did mention the gap analysis and data-driven plan as a big hurdle, and that comes straight out of the gate. And I found it to be overwhelming, very time-consuming. I'm already a morning person, but I was getting up at 3:30 a.m.
Oh my God, that's not morning.
What?
That's not even morning.
I also decided to take some designated time off, and that was part of the saving grace. And so that would be my recommendation for, some of the future students. Anyway, to try, if they can, take some time off around these heavy assignments. I
think I don't know if it was just me, but I think I didn't entirely understand the big picture of what was happening early on. So I think I wasted time, like with this surveys. I don't think I understood that this was setting up a baseline. And I think that, we were given some guidelines to follow. I didn't understand that you could tweak those you could tweak it, to make the questions really applicable. I thought we were, supposed to stick to certain. So I just think that not having much of a grasp of what was expected, what the larger meaning of what we were doing, I think that held me back and made it take more time. And I think I'm still catching up from that with, keep rerunning these surveys. And and then I think this might just be unique to my patient population too, but they're just so positive. So like I give these surveys and it's, 5, 5, 5. I'm like, that's not true. You don't know. I know you don't know what this project is. I haven't told you what the project is, but the question is like, do you have are you comfortable with our roles and all this? They're just so positive. Nobody wants to offend anybody. So that was a whole thing with that. But yeah, I think that was kind of my struggle, was just sort of getting that big picture understanding of what was happening.
Yes, how they said it wasn't linear, that it was very hard to pull it all in together and understand.
Yeah, agreed. I talked to Dr. Verzoni one day, and I was so worked up. She was like, you need to calm down. I can't even understand you. That's literally what she had to tell me. And she was right. She could not understand me. I was just all over the place. So after that, I tried to cool it down a little bit, but it's not easy, Yeah, it was, I'm like, oh my God, it's like embarrassing,
I think we've all been there, Jennifer.
Yeah, she's like, okay, calm down. I can't understand you.
Frantic emails.
Okay. And so following that, what advice do you have for incoming PC740 students? And Donna, this is actually your question, but I know you kind of answered that a little bit in the last question.
And I would like to elaborate a little bit more. So time, the time was just tremendous. The time requirements to get, especially the gap done. And I'm kind of along with you, Julie, when you really don't have the full picture and then you're trying to move forward, push forward, and get that big assignment in. And so time was precious, because I work full time and a lot of you do too as well. And so just trying to get extra time off from work But also, I was out there spinning a little bit. And then one day, my group for the other class said, maybe you want to make an appointment with your faculty member. I don't know why I didn't think about that. And so I would encourage others as soon as possible. Don't hesitate. Contact the continuity faculty. And like similar to you, Jennifer, it was the other hand. I couldn't understand what she was saying because my anxiety was so great. Anyway, to communicate with your continuity faculty early on with any question that you might have would also facilitate, new students into the planning session to do much better.
Yes, I agree.
Yeah, I definitely found, I think I made maybe 3 or 4 appointments with Dr. Verzoni, and it definitely cleared things up, reduced my anxiety, and did give me a better sense of what I was doing and what specific things I needed to improve, which was helpful.
Mm-hmm. Mm-hmm.
And I would say be flexible with the topic. The first topic I chose, I did a chart audit, and while we weren't doing the screening, it was actually gestational diabetes screening, like early screening. And I found that we were not doing it, but of all those patients that should have gotten screening, almost none of them were actually diagnosed with gestational diabetes. So I didn't want to waste time on something that, and I know it's not a PhD project, so I was trying to get away from, I'm not trying to prove whether or not we should be screening. The whole point was to see if we are screening. And so I didn't want to spend a bunch of time on something that might not really make a big difference. Mm-hmm. And so I kind of had to, like 2 more times it always has done with obesity, but just being flexible with the topic, because what you think is a really great idea to start with might in the end not really be a great idea, because you might waste time on something that's not that important.
I think looking at previous projects helped a lot.
Yes, for sure.
I didn't truly understand what this project was until I read through a few, watched some presentations, and figured out how all these ramps work together. I'd never heard of ramps before.
Oh, the ramps. I was like out of my mind trying to figure out what those were.
Yeah, it's almost like it's a specific vocabulary or a specific language to QI. I think, and you don't automatically know what that is. So I think it's like learning a new language, and if you just said a ramp was a chapter, an aspect, or one way you're looking at the project, it would be maybe a little bit clearer, but it's learning that language, which is, I guess, it's kind of an interesting way, because there's the language we all know of medicine, medicine, you don't know what people are talking about, I think it's similar with QI.
Well, that was part of when I met with Dr. Verzoni for the first time. She started saying rampy and C, and it could be this, that, and the other. And I just had to wait a minute. I don't understand what you're saying. And you're right. It's a whole new language.
Mm-hmm. Yeah. Okay. And the last question is, what gives you the most angst about next term? And that one goes to me. I'm not sure. I'm not sure I'm particularly angsty about next term, except that it comes down to you not knowing what you don't know. So I'm okay now.
At the moment.
Yeah. I do know that I tend to get stressed and even start to feel that sense of almost like powerlessness when I'm not understanding. And it's not like in the I just graduated with a master's in October, and if you're reading something you don't understand about a medication, well, you can go back and look it up pretty easily. It's in a textbook or somewhere online. I'm not finding information as readily, clearly available, so that may be an actual stressor that's unique to this project. I don't know, maybe other people don't experience it that way. Maybe I'm not looking in the right places. And then again, like Jennifer mentioned, it's a 2-hour commute, and I know next year I'll be going a lot more to Brooklyn. So there's just this a real life kind of stressor in working that in. But that's what I'm anticipating. Anybody else?
Some of my concerns, I don't know if they're real angst, but I wrote a few of them down. Well, basically, let's say what if the patients really don't get engaged with what I'm offering them in terms of making a SMART goal? There's a chance that they're not ready to change. Although I do see quite a few patients in a week, and so I think I'll surely have my numbers, but I am a little bit concerned that they're not going to be ready to discuss it and move forward with their weight. And then also the team may consider it a little bit more work and not worth the investment, and just give me some flack, give the project some flack. So I'm going to do my best to counterbalance that, of course, with information and appropriate incentives and so forth.
Bribery.
So those are the main ones. Yeah.
Yeah, for sure. Anybody else?
I
Go ahead.
actually don't get to go on with you guys next term. I have to go through the IRB.
Oh,
So that's going to be fun.
why?
Yeah.
Just UK, the hospital I work at, any time that you have to access patient data,
Mm-hmm.
they force you to go to the IRB to make sure it's not humans research. So even though I work there, I wasn't allowed to personally do the chart review of my own patients because I was looking at it as a student.
Oh my.
So I had to get someone to do my chart review based on the data I asked them to collect, and then turn around and put it in to our audit form and, do all that. So
Where do you live? I'm sorry, did I miss that? Where do you live, Mike?
I live in Kentucky. I live right outside of Lexington, but I work at the University of Kentucky Hospital.
Okay. When you said UK, I thought I missed something.
Nah, sorry. But yeah, the Office of Research Integrity has a lawyer that runs it, and they're by the letter of the law. And so I have to take.
How long is this process going to take for you?
I mean, it should only probably be a few weeks because they said I could put in what's called an exempt application because it's a QI project. They just kind of have to review it and make sure I'm not doing research. But where the project moves so quickly, if I have to sit out 3 weeks or something like that, I'll be too far behind. So I have to sit out a term.
Oh, I'm sorry.
Oh my goodness.
Mm-hmm.
Sorry to hear that.
Well, we made it through all the questions. I'm not sure. Donna, did you happen to be timing our discussion segment?
I timed everybody. Do you need those, or it says?
Well, I'm just wondering, have we been talking together? Has that hit about 45 minutes?
Oh no, I didn't time that. I'm sorry.
That's okay. Well, it took 25. Let's estimate it took about 25 minutes to get through the presentations, right?
Mm-hmm. Yes.
We still got a little bit to go.
Yeah, it's been about an hour, right?
Yeah, I think we started out maybe like 10 minutes after noon.
So we would have probably started this discussion about, would you say 12:35?
I think so.
So I think to be on the safe side, we need another 10 minutes of talking.
Okay.
Okay.
We can do that.
Does anybody want to talk about, I know one of the questions specifically was about innovative things that we're doing, tools, shared decisioning, things of that nature, but you can't really put those on your PowerPoint. Do you want to like maybe share those? People can look at those?
Oh, pull them up, you mean?
Yeah,
Yeah.
that's a good idea.
Okay.
And I can,
So just the shared decision-making tool?
or whatever you're implementing.
Okay.
So like, for example,
One of the tools.
I'll show you what I'm doing here.
Yeah.
Okay.
Let me share my screen here. Hold on. So part of what I'm doing is provider algorithm and checklist. You guys see my screen?
There you go.
It's if I can make this bigger. Oh, too big. So this is a handout that I was actually going to print out and provide for all the providers, but over here on this side, which would be the first page, I have a checklist, and this goes with my case management log. So as they go through this and do all these, then of course those would accrue points on the case management log. But the next pages are screening algorithms for smoking, and then former smokers, and then if someone tells you they're not ready to quit, it gives you ideas for treatments, follow-up, things of that nature.
Wow.
And then assessment of nicotine dependence, a table that has community-based supports, and then the last page gives the pharmacological reference for the different nicotine replacements or pharmacological cessation therapies.
Fantastic.
That is, yeah, really complete. Did you create that algorithm yourself, or is that?
No, they actually came from this 2018 ACC expert consensus decision pathway on tobacco cessation treatment. So I kind of used that as my major guideline. And then I formed my right care kind of checklist based on what was recommended in the guideline.
Yeah.
Just get out of screen sharing. There you go. Does anybody else have like their aid or whatever they were wanting to use? We all talked about them, but
I'm just trying to pull mine up.
Yeah, I can pull mine. Mine's open. Well, it's trying to open, I think. Yeah, I can share that real quick. So are you guys able to see that?
Yes.
Okay. So this is kind of like a checklist so the provider knows, what to do, like, again, the right care checklist. Right. And then this first one is for new OB patients. So they kind of fill in, it's like a little kind of like a little survey for them to kind of talk about, how they feel about this pregnancy, or if they've been pregnant before, how much weight they gained, and did they lose all that weight, and then what their barriers are. And then down here, this is where they come up with a smart tool with the provider, like I'm going to walk 30 minutes 3 days a week or whatever it is. And then this half of it is same thing, a checklist. And this is the weight gain tracker. Again, so if the patient is identified with a return OB visit, if they're identified to have gained too much weight, and I'll show you kind of that screening tool, then they'll again fill this out and again come up with a SMART goal at the end. And then our screening will look like, this is for the return OBs. The new OB is just based on BMI, but the return OBs, so I found these on the CDC website, and you chart basically how many weeks pregnant they are and how much weight they've gained. If they're in the blue, they're normal, so that's healthy. And then if they're outside of the blue boxes, it's either too much weight or too little weight. And so that's for each patient. So it's all based on their pre-pregnancy BMI. So I thought that was a cool little way, and it's really easy, and that no one has to sit there and think like, okay, how much weight should they have,
right?
How much weight should they have gained, is it, because the first trimester it's like 0 to 4 pounds, and after 20 weeks it's 1 pound a week, depending on what their weight was. So that gets a little tricky, and that's asking a lot of people to do in a short period of time. So I thought these charts were pretty cool, so they can just see once they're outside, then it makes them eligible to do that. Yeah, so that's my thing. I'll turn off screen sharing so Julie can put her thing up.
Oh, I'm still trying to pull mine up. I'm sorry.
I've got something to show you.
Okay.
Actually, I'm thinking forward. This is something that I'm probably going to utilize in one of the cycles. The first shared decision aid is it's a SMART goal development sheet. And so that's kind of self-explanatory. But then I thought I'm going to make it simpler at some point. And so I made this tool I'm so excited about. And I'm going to laminate it, have it in each room, along with some other resources. But it's the top 12 lifestyle changes to promote weight loss. And so I'll have them just pick one that's appealing to them. And then they can develop a SMART goal from it. So let me find it again. I just had it. Here we go. I'm going to turn my camera around. Let me know what you think.
Okay.
Let's see. Hold on. Can you see it? Are you able to see it?
Hold
It's
on.
really shiny, really bright. Maybe
hold
click
on.
on your screen.
Do that?
Oh,
There
yeah.
you go.
Oh, there you go. Now it's nice and clear.
So it should say like the top 12 lifestyle changes to promote weight loss. Drink water, trim your portions, eat slower, yada, yada, yada. So I thought it'd make it easier for them to pick a lifestyle that they want to change and then turn it into their own personal SMART goal.
Oh, wow.
Yeah,
That's great.
That's good.
That is really nice.
It's nice and colorful and succinct, so they can look at it and pick something out without too much difficulty.
Yes, because I'm worried about them taking too long in the patient room because I'm capturing them when they're coming in with a sinus infection or, you know, a bellyache.
Mhm.
There you go.
Excellent.
That's nice.
Now, Donna, since you had to make your own tool, do you have to go through a different process of validating that?
No. Well, as far as I know, I don't. This is actually I took it from several articles that for evidence-based weight loss, lifestyle changes for weight loss, and so I don't know yet because the other ones were modified.
I don't think so. I made my tool, and Dr. Verzoni didn't say anything about that.
Oh, that's good.
Yeah.
Plus, I'm not measuring their engagement by this tool. It's the SMART Goal tool, the SMART Goal Development tool. This is a facilitator, so they can meet that goal.
Interesting.
I have mine if you guys are ready
Yeah.
for it. So this is my 5Ds. Can you hear me?
Yes.
Okay, good. This is my proper prescribing, antibiotic stewardship, and urgent care. The 5Ds of antibiotic stewardship checklist for the providers. And I got this from Vancouver Health and adapted that. So each of the questions is going to be 1 point, and there's 10. So they start with the drug. Is the antibiotic indicated? Has a culture been done? Is it the most appropriate? And can they narrow it down? Because we've had some people that are using, for instance, Augmentin for strep throat, things like that. That's too wide of a coverage. And then the proper dose, we see that especially a lot in pediatrics, is the dose appropriate? There's a lot that are actually too low. And is the route appropriate? So in urgent care, we're pretty much just PO or IM. And the interval, we also see some issues with that. And then the duration, of course. And then the total score would be 10 points if they do everything perfectly and they fill it out themselves, but then I'll be chart auditing. And then so I tried to do very plain instructions that were hopefully easy to follow. And so that would include bronchitis, mostly sinusitis, acute otitis media, and pharyngitis. And some people prescribe, they may call it a cough or an upper respiratory and give antibiotics when they shouldn't. So I'm trying to encompass all of the possibilities. And then I have this from the New York State Department of Health, which is the prescribing guidelines. And they're so concise and thorough that these are going to be printed and with the 5Ds checklist and also at the desk, along with references if they want to look at the whole guideline. And this is nice because it really also touches on, do they really have a penicillin allergy? Because we see a lot of that. They don't really ask, do they have a real allergy? So that's my tool.
That's beautiful. And I almost wish we had one of those where I practice because that was really helpful. Cynthia, how did you, I'm actually impressed with the beauty of everybody's tool, but how did you get the background? Where did you find that?
Oh, I used it from Word documents. It's actually a resume background.
Okay.
And
So it's like a template kind of thing?
Yes, it's a template, and then I inserted the picture of us doing our Ebola training because I thought it kind of goes with antibiotics, infectious disease type things.
Yeah.
And that was a very fun moment for everybody. We had a lot of laughs, so I thought that'll kind of lure them in, hopefully. But the template itself, just so you know, was so hard to use. Like, you make one little change and everything gets displaced because it's a resume template. So it's very challenging, but
it looks great. Yeah.
Thank you. Thanks.
So I'll try to pull mine up here. So just no, that's not the one. Sorry.
That's okay.
So this is just, see, I feel like you guys are so much better looking. But this is my shared decision aid for my patients. So the Caribbean population eats a lot of fish, so I'm trying to pull them in that way. It's just goal setting. You've got the short-term goals, your long-term goals, and then fitness goals. And because we need to improve follow-up, there's the date of the next visit right on there. And for the process ramps, please open on the right screen. Okay. So this is my provider checklist. I almost wonder if there's a better way to do it, but you see up top, there's right about here, there's the patient information, which will get pulled off, but that's how I'm going to be tracking. Then here's the screening, the height, weight, and the BMI. BMI, so we're just dealing with obesity. So if it's greater with 30, continue to the checklist. The checklist helps the provider break down into which class of obesity, because as you know, there's different management depending on what level of obesity. And then you can just follow down and they can check off. There's actually a lot of history and labs and the physical evaluation aspects. So there's that. And then my other one, I think that's it. Because the other provider, the case management log is pretty straightforward too. And the difference between them is the checklist I just showed you is for the provider to use when dealing with a patient. This is more just tracking right care of the patients, making sure that the checklist was complete, but also did they progress, did they do their follow-up appointments? Did they make a decision as to how they want to manage their weight? And then that helps us score that this way. So those are my tools.
Excellent.
Great.
I like the first one. It's very concise and clear for the patient to just simply make their goals.
The decision aid.
That's very nice.
Thank you. Oh wait, and I want to unscrew. You don't have to stare at me. Here we go. Are we good? Okay. All right. So did everyone share? I might have lost track.
I think so.
Good. And how are we for time?
That was fun to see everybody's.
It was. So I think we've hit our time. I think we've hit all the topics we're supposed to talk about. So does anyone have anything else they want to say? Just as a reminder, there's a reflection there's always the reflection, right? We're trying to reflect so much. There's a reflection to hand in after this, so just don't forget to do that. And
then we each send in the link, right? With our...
Yes. So yeah, I'll stop broadcasting once we're done. And then as soon as that hits my YouTube, I'll email that out to you guys.
All right. Thank you, everybody. It was a pleasure.
Yeah,
Thank you.
Great. Right, enjoy the rest of your day.
Thank you. All right. Let's stop the broadcast now, guys. Have a good one.
Bye.
Bye-bye.